I can hear you okay right now. Yeah, we're having trouble. Okay. So if you can hear me, I'll just go ahead and get started. This is a 26-year-old female. She is another patient of a coworker of mine. So I'm seeing her blood pressure 16/69. Heart rate was a little bit elevated, but from what I could tell, that is her normal heart rate. That's not out of the ordinary for her. Temp was okay. That she had an ultrasound, an abdominal ultrasound done. I believe it may have been in January or November or December, and I saw her in the end of January, and it was normal. Ultrasound was normal. She was diagnosed with Hep C around 4 or 5 years ago through this PCP. At one point was incarcerated about 2 years ago, and whenever I spoke to her, she said she thinks she may have received medication there to treat Hep C, but she did not finish it and does not recall what the name of it was. So she wasn't sure. She started drug use when she was around 13, started snorting it and smoking it initially. And then she started using IV drugs around the age of 21, but only did that for about 4 or 5 months. She stopped her drug use on her own. She stopped it about a year ago. She's not been through any formal kind of rehab or MAP program, but she has used, just from what she said, just about everything, including meth and heroin, benzos, opioids. She's used just about everything. She does continue to smoke about a pack and a half to 2 a day, and she does drink alcohol on occasion. Overall, she's a pretty healthy female. She does have a history of bipolar disorder, is seeing psychiatry for that, and is currently on Invega. Her bipolar disorder is very stable on the Invega. She's doing very, very well, and that is the only thing that she's taking regularly. She is immune to Hep A. She was Hep A antibody positive and reactive to Hep B on the 26th of December in 2064.75 weight. BMI was 32. And then labs. White cell was 8.5. Hemoglobin and hematocrit were pretty good. Her platelets were 243. Kidney function was good. Glucose, no history of diabetes. Her blood sugar was 86. Proton was 9.8. INR was 0.9. Albumin was good. ALT and AST have been stable at 29 and 23. Her alk phos was at 115. APRI was 0.24. Her child Turco-Pu was 5, and her MELD score was 6. Other labs, vitamin D was on the lower side, as she is not on any kind of vitamin D replacement over the counter or prescription. HIV was negative. Her genotype was a 1A with a 506,000 viral load. Fibrosis biomarker was 0.04, which was an F0. With Invega is the potential for any interactions with any of the treatments that we use for. And I thought about the Mavrit for treatment just because of a shorter duration, and hopefully she could be more compliant. So that's all.
Thank you so much, Shana, for yet another awesome case presentation. We truly appreciate it. And you did a wonderful job. So thank you for bringing that to the session today. Before we jump into addressing the questions that Shana had, did anyone have any clarifying questions or comments for Shana in the case? Feel free to unmute.
Shana, this is Jennifer Boyd from New River. That's really impressive that she was able to get sober on her own. That'll be so nice if you can treat her Hep C because she's so young. My question was, and you might have said this, but I forgot, is she at risk for pregnancy? Or does she use does she need
No, did I probably didn't put that on there. No, she has had a tubal ligation.
Thank you, Jennifer.
I don't think I put that on there.
Yeah, no worries at all. Anyone else with any comments or questions for Shayna?
Shayna, this is John Gilfus at the Hub.
Yes.
Do you know what the normal range is for your rheumatoid factor? There's I don't know if 30 is high or low or normal.
Look it back up.
I tried to Google if there's a set normal range. It looks like there's a lot of different normal ranges depending upon particular lab.
I think hers was normal according to our labs.
Okay, beautiful. Thank you. Thanks.
Hey, Shayna, this is Kaylee with the Hub. I just want to make a couple comments about your case, just to point out, I think you did a great job presenting, and I know she's not primarily your patient, but one of the things that I was looking at is that, she'd mentioned possibly having treatment a couple summers ago for hepatitis C.
Yes.
And it kind of makes it a little complex if she's not sure what she had or how long she took it. She mentioned she didn't complete it. So I just kind of wanted to point out, whenever we hear patients that have reported a history of hepatitis C treatment, one of the things we have to consider is, what type of treatment they may have gone through before, because it could influence their treatment now. And so one of the things to think about is just kind of the history of hepatitis C treatment progression. So if this was somebody that had, if she's 21, but I mean, if she was somebody that had been treated several years ago, really the treatment options were limited to interferon and then eventually interferon and ribavirin. And in those cases, we wouldn't necessarily consider her treatment experience. But now that we've have these direct acting antivirals, and that landscape really changed, not too long ago. I mean, within the last 6 years, if she's saying that she was treated just 2 years ago, there's a high potential she did have at least treatment exposure with one of these agents. So a couple things to ask. I'm not sure if you know where she was incarcerated at, but it tends to be in West Virginia. We really didn't have hepatitis C treatment accessible to most people unless they had advanced fibrosis until really late 2019. So it was probably not likely that she did get Hep C treatment in jail unless it was some kind of specific program that they had where they're treating inmates, but not likely in West Virginia that was the case. Sometimes people get confused and they think when they say they've had hepatitis C treatment, it's actually been that they've gotten the Hep A and B vaccines, but they just think that was hepatitis C treatment. So one of the things you might want to ask is if she can remember, was it pills that she took for her Hep C treatment or was it shots? If she says, yeah, I got a shot for it, if she just got one shot, it was probably a vaccine, or even if she had 2 shots, probably just the vaccines, and the fact that she's immune to both hepatitis A and B, that's probably what I'm suspecting is she got those vaccinations rather than actual Hep C treatment. But if she does tell you that she's had pills, then maybe ask specifically, how long was she taking them for, to try to differentiate what kind of treatment it might have been that she'd had. I think as far as your assessment, as questions about treatment for now, and then certainly that interaction with Invega, I'll let Rachel touch on the specific interactions, but her 4 treatment options, if we didn't think about interactions at all, being that she's genotype 1A and we don't have any concern for liver fibrosis or cirrhosis, would be Harvoni, Zepatier, Mavyret, or Epclusa. Now, taken into consideration her insurance coverage, she's really limited to either Mavyret or Epclusa. Of those 2, either one would be a good option for her, but with the Invega, there's this potential interaction with the Mavyret, just because that it's a inhibitor of I think it's PGP it's an inhibitor, and then that Invega is a substrate. So it may have some interaction. Now it's not a absolute contraindication, but Epclusa should be okay. So it would, be for 12 weeks, and that's just one pill once a day. It sounds like if she's, in a really good place, she probably is taking this treatment seriously and won't, and will be able to take that medication even if it is for 3 months. It's only once daily. Okay. Do you have any other questions?
Shayna, you are muted.
Oh, okay. No, that was my concern, was the interaction with the Invega, and then, with the previous treatment too, definitely. Or, what she says is previous treatment.
Yeah, I try to point that out just because I've had that a few times now when patients were incarcerated and they said, well, they told me I was treated for Hep C when I was there. And then when they describe it a little bit more in depth, they're like, well, I think I got 2 shots, and it just doesn't match up with our treatment. So that's when I try to point that out now, because I think a lot of times they hear hepatitis and they're under the impression it's a Hep C treatment, but it's just vaccination.
Okay.
Rachel, I noticed you unmuted.
Yeah, I'll just chime in. As far as the drug interaction goes between the regimen options, Kaylee nailed it. It's that P-glycoprotein or PGP inhibition. So there's the risk there is the increase of the paliperidone or the Invega. So it's a theoretical risk because we know that's how the two of those work as far as metabolism goes. So there's no recommendation as far as, changes in dose for the Invega or anything like that. Just monitoring for toxicities with it is the main thing. So like the CNS, cardiovascular, those sort of things are what we would worry about. It's not one with the Epclusa, but depending on, like Kaylee mentioned, if she, whatever regimen she was treated before, if the Epclusa wouldn't work, but you'd have to go to Vosevi, that would have the same interaction as the Mavorite. So Epclusa alone does not have the interaction, but both the Mavorite and the Vosevi have that sort of, caution to monitor the patient. Nothing that's contraindicated, just the monitoring for those effects.
Thank you, Rachel, and thank you, Kaylee, too. Any other hub members with any recommendations or thoughts that you wanted to share with Shayna? Dr. Gill?
Yeah, and I just couldn't agree more strongly with what Kaylee said. I'm almost certain that she did not get hepatitis C treatment. That time frame involved, and I think that's a state facility, if I'm not mistaken. We were privy to sort of the criteria that the state institutions use to treat patients for hepatitis C, and it was really fibrosis based up until very recently. And I just don't think she actually got treated. Agree 100% with what Kaylee said. So.
Thanks, Dr. Gilfus. Anyone else with any questions, comments, thoughts? Feel free to chat in as well. And Shayna, did you have any questions, any other questions about the case, or?
No, you guys covered it. I appreciate the help.
Awesome. That's great to hear. Thank you again so much for the awesome case. And if anyone does have any other questions throughout the session that they can think of, just feel free to chat it in and we can always revisit it as well. So, all right. Thank you so much, Shayna. Thank you all for the great questions and recommendations. And Carolyn, I can pull up that one slide and just turn things over to you. Thank you.
Sure. Thank you. And I do just have the one slide, and I'll have to say I did not put this slide together because just, life gets in the way, but Elizabeth actually put it together for me this morning. And what I really wanted you guys to see on this slide was the references that I'm using for my little talk today. And so my name is Carolyn Kidd, and I'm a clinical nurse educator with the Mid-Atlantic AIDS Education and Training Center. And we are charged with providing HIV and AIDS education to healthcare professionals in West Virginia. And that's what I love doing the best out of life, other than ever being able to see my grandbabies, and that will come at some point, won't it? I gave this same talk to the folks that attended Patient Care Conference last Wednesday for the Positive Health Clinic, because I found it to be something that they should hear. So essentially what I'm going to talk about are vitamin D and calcium and some other supplements that do not prevent cardiovascular disease in patients. So bear with me a little bit, and anybody have any questions, you're welcome to throw them out at any time. You can put them in the chat, or you can ask later, or you don't have to ask anything at all, whatever you're comfortable with. So this is really just a summary of 2 reviews regarding the health promises of dietary supplements, particularly vitamin D and calcium, with experts from these 2 studies so far concluding that intake should be avoided or discouraged, actually, to prevent cardiovascular disease. And I thought, this really stood out to me, because I think that we all, especially me as a consumer of healthcare, and then you all as providers, this was something that I really did not know until I started looking at these studies. So there were 2 reviews that this paper looked at. The first one was published in January of 2021 in the Journal of the American College of Cardiology. And Dr. Mikos and colleagues stated that supplemental vitamin C or vitamin D for cardiovascular health should be discouraged because there is no solid evidence, including any recent randomized randomized control trials, and that it provides any benefit for cardiovascular risk reduction. And also, if I'm talking too fast, somebody just say something to me and I'll slow down a little bit as well. So again, promoting vitamin D for cardiovascular health should be discouraged at this time, related to what we know currently and as recently as January of 2021. So calcium supplements, and we'll talk about these a little bit more in detail. Vitamin D, I'm sorry. So vitamin D doesn't appear to cause any harm, but people would be better off getting it through their diet, and also moderate sunlight exposure, which is, in West Virginia, sometimes that's a little difficult to do because it's so cloudy all the time. So calcium supplements, widely used for bone health, may even cause cardiovascular harm. For this reason, they should be taken cautiously. The researchers advised in this particular study. Getting enough calcium through diet should also be encouraged. This particular provider, or the author of this study, said she was a little more concerned about the calcium. She said there is some inconsistency in the literature, but she thinks that it's enough of an inconsistency to be worrisome for providers and consumers of these supplements as well. And there are enough studies suggesting harm, and that there should be some counseling around this, and that patients should be aware of potential risk. And the second review, and this was led by a Dr. David Jenkins out of Toronto, Canada. He and his colleagues came to similar conclusions in an analysis of 35 randomized controlled trials that evaluated the harms of and benefits of vitamin D, calcium, vitamin C, and multivitamins. The data continue to show no consistent benefit to prevent cardiovascular disease. So again, just as a reminder, these were looking at supplements related to the prevention of cardiovascular disease and how they actually do not help to prevent. The data continues to show that there is no consistent benefit for preventing CVD, MIs, stroke, or for all-cause mortality as well. Let me see. So we know that a lot of people in the United States take both vitamin D and calcium. I'm one of those people because I have osteoporosis. And, we think, well, take more calcium and you're going to be good to go. And that actually is not the truth. About a third of adults in the US take both of these supplements. Older adults, the consumption is even higher. It's even higher in women who are over the age of 70 who take calcium. Excuse me. So what is the evidence? And does anybody have any questions or any thoughts so far just about the general information on the supplements and how they don't prevent cardiovascular disease?
Carolyn, we don't have any chat questions in yet.
Okay, that sounds good. Then I will go on. So what is the evidence? Some observational studies have previously linked low blood concentrations of vitamin D as measured by a blood test for vitamin D in blood to a heightened risk of cardiovascular disease, including coronary artery disease, MI, stroke, peripheral artery disease, and heart failure. I think that low levels of vitamin D are associated with multiple poor health outcomes, including obesity, diabetes, and cardiovascular disease. People in poor health in general have low vitamin D levels, but associations don't necessarily, and those are the people that are at increased risk of CVD, but associations don't necessarily mean a causal relationship. So my expertise is in HIV itself, although my expertise falls below Dr. Gilfus, who is also on this call. But we know as HIV educators and care providers that the ongoing, that HIV infection affects every single body system, including the skeletal system and the heart as well. And so many people who are living with HIV, who are on medications, seem to have an increased risk of loss of bone density and fractures in hips, especially at a younger age. So I think I'm actually going to stop there right now. It just was, I thought, a very interesting observation about maybe the myths that are involved among consumers of health about the benefits or the non-benefits of taking supplements to prevent cardiovascular disease. And since you all are primary care providers in some way, I would love to hear what your thoughts are on this.
Well, first and foremost, thank you so much, Carolyn, for going over all of that. Super interesting. And I wish I was a clinician to be able to take part in the discussion, but I always enjoy listening. So as you said, anyone who has any comments, thoughts, feel free to unmute or chat in.
Yeah, it's, and I don't mind, just being quiet for a minute and waiting.
I guess my first question, well, two questions came to my mind. One is, how many people are actually taking these things for cardiovascular health, and how many of them are in the boat that you said you're in, Carolyn, where you're using it because your bones need it?
Mm-hmm.
And secondly, how do we convince cardiologists that hearts sit in bodies and we have to maintain the rest of the body while we're maintaining the heart?
Yeah. And that's, you know what, Dr. Rexroad, that's a really interesting observation, because a lot of times, and this is not to disparage any specialty at all, because we all have our own specialties, but sometimes specialties get locked in their own silo and they're not able to see outside of what they do in the provision of care, and how, you know, many other diseases, many other body systems interact. And I know that they know it in their medical brain, but again, people really do get kind of locked into their silos, and it's hard to, but the one, hey, would you bring up that, what do you call it? PowerPoint slide again. So the one reference, the second one at the bottom, that was, oh, they were both printed in the Journal of American College of Cardiology. So, you know, there's a good thing right there. That was printed in their own specific medical journal. So hopefully people will become aware. And also, I think just doing this today too, like I said, my specialty is HIV as an educator. And if everyone that's on this call today isn't already aware that HIV does affect every single body system from your head to your toes and every single thing in between. So we do have to look at bone health and brain health and lung health, cardiovascular as well. And, you know, I take the calcium and vitamin D because I was advised to do it by my primary care provider for my bones. And then I read another thing that people, if they are taking it, to take the lowest milligrams of calcium per day, which is what, about 600 milligrams of calcium. I think maybe women are supposed to get between 600 and 1200. I don't remember. But if you're going to take it at the lowest possible dosage that you can, which is 600 a day. And then how do you get patients to do, you know, what you're asking them? How do patients who are in food deserts get healthy, calcium rich and vitamin D rich foods? Do they know how to cook? I mean, there's so many things involved in trying to eat and maintain a healthy lifestyle for all of us, you know, especially in this time of COVID. Nobody wants to go anywhere. And people are getting sick of their own cooking.
Well, I mean, what I have personally done in my practice is to tell women, you know, postmenopausal women need 1200 milligrams a day of calcium. That's the recommendation. So do younger women on Depo-Provera for birth control. So what I have told them for years is to take half of that as a supplement and get the rest out of their diet.
Right. That's a great thing to say, because that's actually what, not these two articles, but the other article I was reading was to go with the lower dose and then supplement with diet. And I'm so glad you brought that up, Dr. Rexroad, because I totally forgot about that. That's awesome. Anybody else have any? Oh, go ahead.
This is Kaylee. No, this is Kaylee. I just want to thank you, Carolyn, for that great didactic and presenting that new evidence. And I also want to applaud Dr. Rexroad, because I think you just alliterated everything perfectly. You know, this didactic was specifically focusing on vitamin D for cardiovascular risk reduction, and that it's not appearing to be beneficial. But, you know, coming from a hepatitis C standpoint, and then also just kind of understanding how HIV and hepatitis C, they're both these pro-inflammatory conditions. And so vitamin D is well described as being beneficial for both HIV populations, as well as patients with liver disease. And so, and of course with bone health as well. So, you know, just kind of as primary care providers, when you're doing your counseling, you know, from that approach of if vitamin D is needed, we can counsel them from these other aspects, but maybe just tell them that, hey, you know, we don't see any benefit for cardiovascular health, but it is known to be a down modulator of inflammation. And so having hepatitis C or HIV or, you know, are two conditions that are pro-inflammatory. And so this is well described to kind of decrease that inflammatory burden.
Mm-hmm. That's really excellent, Kaylee. Thank you. And I'm done with my didactic, our discussion today. I mean, I'm done with my part. I'm not done with your part if you have more questions. And I know Mithra is probably going to put me on the schedule again at some point for another didactic. And the next one will be HIV specific. So I have 2 questions for you guys. If you have something that you especially want me to talk about that is HIV related, please, you can either send me an email or you can send it to Mithra or Elizabeth. Either one. Mithra, it looks like she wants it, and then she'll pass that on to me. And then from my HIV hat, I just want to ask you guys, are you all prescribing PrEP for HIV prevention? Hi, Tammy. Yay.
Yeah, I haven't, but it's like I know it's there and, you know, have had the discussions with patients.
Uh-huh.
So, you know, it's going to happen one of these days. But
Yeah.
and that's one of the things I've learned out of this echo is about, you know, the PrEP and the fact that we should be doing it.
Great. Are there any certain barriers that you face, Dr. Rexroad, about PrEP prescribing? Because you're in a very rural area of West Virginia, a beautiful area, but quite rural.
I think just awareness and then patient education.
Mm-hmm.
Those are 2 things that that I would cite. You know, awareness of, but among our, you know, our group, and then also just patient education that it's out there and they could be asking.
Right. Well, I'll tell you what, because I just thought of this now. My colleague Sarah Vincelli, she actually put together a very nice PrEP graphic for patients and patient education. Would you like me to send that to you? Would anybody like it to be sent? And I'll tell you what, if you do, let Mithra know, because then she can give me all your email addresses of those that are interested, and I will pop it on off to you. I know Kaylee has done a really wonderful, probably more than once, didactic on PrEP, but we know that there are barriers to PrEP provision in West Virginia. And if there's anything that we can do as HIV educators to help you overcome those barriers, please call on us, because we want to do that. We know that's a wonderful HIV prevention method that's in the toolbox. So if anybody on this call, or you guys know of any of your colleagues that might want the PrEP infographic,
Carolyn,
give us a shout out.
I was also thinking, if you wanted to just go ahead and email it to me, I can distribute it in the recap email. That way everyone can just
Oh,
review it that way as well. Does that sound
I will do that. Awesome. Thank you, Mithra. Appreciate that.
Thank you so much. We really appreciate it. And Tammy,
Thanks.
I noticed you unmuted too. Did you want to share your experience with PrEP?
Who are you talking with?
Sorry, Tammy. Yeah, I noticed you had unmuted.
Oh,
Yes, about PrEP. Did you want to just share a little bit about your experience?
yes. What I was going to say is that when I first started to hear about PrEP, I always associated it with Truvada. And Medicaid pays for Descovy, which is about the same thing.
Yeah.
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 You know, if I have a patient that can be a pill taker and is willing to commit to coming in every 3 months for STI testing, and also, I've stressed the importance of not having multiple partners and being responsible. And so it's worked out fairly good here.
Oh, that's really good. Where did you say you are, Tammy?
Sunnyside Health Center. We have a small clinic inside the Kanawha Charleston Health Department.
Oh, okay, great.
Part of Cabin Creek.
Okay. Descovy has been approved for PrEP, but only among men who have sex with men, not for women, which is a whole nother 2 days of debate.
Right.
But does anybody else have any comments or questions about anything? Who has good recipes to share? I'm tired of cooking the same old thing.
This is Kaylee. I just want to bring up, I think a future session, I'm not sure when, but we'll be doing a PrEP update during one of our echo sessions. I'm not sure. It might be the second half, but we'll touch base more about Descovy as PrEP. And as Carolyn said, yeah, for MSM, either Descovy or Truvada. With Truvada in women, or if the risk is injection drug use, Truvada would be the only treatment that's currently approved, and you can still get that approved through Medicaid. You just have to appeal it and list the rationale. So it would just say that Truvada is the only recommended regimen, and they will approve it. It's not been an issue yet. I think it even says in their prior auth paperwork, Descovy, and then lists, unless a female, and then they'll approve Truvada. But the other thing is we'll update as well on some of the newest, the injectable data for PrEP, because there's some new data on the injectables that should be available in the near future as well. So we'll touch on that.
Oh, thank you, Kaylee. And Kaylee, she's an awesome nurse practitioner, by the way. And she does PrEP here in Morgantown. So she knows a lot more about the logistics of PrEP. And I always appreciate her input.
We can also attach the curriculum for this first half of 2021, just so you all can see it again and have a little refresher of the topics to come. But like Carolyn mentioned, as always, if you have any topic requests that you'd like to hear as a didactic, just email both Elizabeth and I know I gave a thumbs up, but it's both of us on board. So just shoot us an email and we'll make sure to have it on the next half of 2021 for sure.
Yeah.
Any other comments, thoughts, or questions? Any good recipes, like Carolyn said? I'm getting tired of my cooking.
I'm trying to eat more Mediterranean. I've been doing pretty good, but I'm sick of cooking. Sick of it.
You're not alone.
I will tell you, Jeanette and Sarah and I, all three of us are nurse educators, and because of COVID, we're not able to get out in the field and actually do face-to-face training. So we've been doing a lot of webinars, but we are so looking forward to getting back out in the field and training y'all face-to-face. And y'all know that we'll come and see you and provide what you need at your convenience, not mine. If you need something at midnight, I'll be there. Okay. But we're really looking forward to getting back out and traveling around our great state again. That's all I have.
That's very kind of you, Carolyn. Thank you so much. Truly appreciate it. And the didactic was awesome. So thank you for presenting that today. If there are no further comments or questions, I'll give you all 15 minutes back to your day. The only announcement that I do have is our next session will be on March 11th, and Kaylee Berner is going to discuss why genotype and fibrosis matter. So keep an eye out for that reminder, and we'll see you all next time. Thank you so much.
Thank you. Bye-bye.